Syndromic approach to dizziness or a diagnosis-based approach? Which is better?
Hi, Peter Johns here, known as Vertigo Doc on Reddit, and as Associate Professor in the Department of Emergency Medicine at the University of Ottawa. In the past several decades, there's been a lot of changes to the way that ER docs and other medical professionals think about vertigo. So there's a lot of new information to convey to those who struggle when they see the dizzy patient. What's the best way to teach them? Do they need to know how to put their patient into a particular vestibular syndrome, or can you just teach them a few key diagnoses?
I recently came across this paper from Mary McLean, who surveyed emergency medicine residency directors across the U.S. about how they felt about the HINTS exam and vertigo education in general. And good news is that most of them thought that the HINTS exam was a valuable thing to teach during emergency medicine residency. I certainly agree with that idea. Dr. McLean also asked them if their residency programs taught the syndromic approach to vertigo, and although the answers weren't in the paper, she kindly emailed me the answer. And about 2/3 of the residency directors said yes, they did teach the syndromic approach to dizziness. But what exactly is the syndromic approach to dizziness, and how does it differ to a diagnosis-based approach, and is one approach superior to the other? Now, the answers I'm giving are largely based on my opinion and real-life experience with seeing dizzy patients and teaching vertigo to others over the past more than 20 years. There hasn't been any literature that tried to answer this question that I'm aware of. First, I'm going to give a short answer, then I'll follow this with a medium-length answer, and then a long answer where I'll look at this issue in some detail. A syndromic approach asks you to first put the dizzy patient into a particular vestibular syndrome, of which there are basically three that are commonly used: AVS, TEVS, and SVS, which stands for Triggered Episodic Vestibular Syndrome and Spontaneous Episodic Vestibular Syndrome. And from there, you apply the same bedside diagnostic tests that you do with the diagnosis-based approach. A diagnosis-based approach is where the emphasis is to lead you as simply and straightforwardly as possible to the most common and dangerous causes of dizziness and vertigo. And those are BPPV, vestibular neuritis, and posterior circulation stroke. And the keep it simple principle would suggest that adding an extra layer of complexity by first trying to fit your patient into one of those various vestibular syndromes would not be the best way. And now the medium-length answer. First, let me make it clear that I'm not talking about those patients with a general medical cause of dizziness like a GI bleed or carbon monoxide poisoning. Those general medical causes will have other features that will make you widen your differential diagnosis. I'm talking about vestibular disorders that involve the end organs of balancing the inner ear, the cerebellum or brainstem, or the connections between them. When we are looking at a dizzy patient suffering from a vestibular disorder, there are two main objectives. The first is to identify patients who are at a high risk of having a dangerous cause of dizziness, mainly strokes. And once you determine that a dizzy stroke is in the differential, make sure that you ask about what I call the central features. These are things that are sometimes seen in dizzy strokes, but should not be seen in benign conditions such as BPPV or vestibular neuritis. And these central features would be a new significant headache or neck pain, which would make you think of a cerebellar hemorrhage or vertebral artery dissection, the typical stroke symptoms such as focal weakness or paresthesias, the so-called dangerous Ds, diplopia, dysarthria, dysmetria, dysphonia, and dysphagia, or seeing vertical nystagmus at rest, but not during the Dix-Hallpike test where vertical nystagmus is commonly seen. And finally, if your patient is unable to walk unaided, you should be concerned about a dangerous cause of dizziness. Now, some of you may be saying, but the HINTS study showed that only about 20% of central causes of vertigo have general neurologic signs. Well, let's look at a recent study by Ole, of which I was a co-author, where he found that 86% of the patients with a serious diagnosis, which were mostly strokes, had cerebellar deficits such as diplopia, dysarthria, dysmetria, dysphagia, or ataxia, and 48% of them had either a motor or sensory deficit. So screening for central features is clearly a good thing to do. And after that, the second objective is to try and make a definitive diagnosis. This is true whether you are using a syndromic or a diagnosis-based approach. And that's because the easiest way to rule out a dangerous cause of dizziness, mostly strokes, is to definitively rule in a non-dangerous cause like vestibular neuritis or BPPV. And you do that by using the HINTS exam or the Dix-Hallpike test in the appropriate patients. Then you can provide the appropriate treatment like the Epley maneuver for BPPV or vestibular physiotherapy for vestibular neuritis patients. Now, which approach is best suited to meet these objectives? Does putting your patient in a SEVS versus a TEVS syndrome help a non-vertigo expert? I can't really see that it does. The disadvantages are that the syndromic approach is confusing for the non-vertigo expert and adds a layer of complexity which just muddles the already murky water of vertigo. I can see that it may be useful for vertigo experts who are willing to spend much time and energy to diagnose all of the vestibular disorders, of which there are many. But the majority of the patients that a dizzy expert sees in their clinics are not highly time sensitive for a diagnosis as compared to those seen in the emergency department. In addition, patients presenting with a vestibular disorder don't always fall neatly into these vestibular syndromes, making the syndromic approach not helpful at all in these cases. The diagnostic approach is to teach just a few key diagnoses and not worry about TEVS and SEVS. The advantage is that you're using the same evidence-based bedside test, the Dix-Hallpike test and the HINTS Plus exam, without confusing you with terms that sound more like airport codes than something dizzy patients would have. And this less complex approach allows you to save a little extra brain bandwidth so you can learn about the variations in presentations of the important causes of dizziness. And now on to the long answer. An early approach to dizziness vertigo was the "what do you mean by dizzy" approach, which relied on the patient's description of the sensation of dizziness to put them into 4 different categories: vertigo, presyncope, disequilibrium, and nonspecific dizziness. But it's been shown that the patient's description of the sensation of dizziness they're experiencing doesn't allow you to rule in or out any cause of dizziness vertigo. So the "what do you mean by dizzy" approach is no longer recommended by most vertigo educators, including myself. The first vestibular syndrome defined by Hodson and Balow in 1998 was the acute vestibular syndrome, and it's very useful. I teach this syndrome to my learners because this is where dizzy strokes hang out and try to fool us into thinking that it's just a case of vestibular neuritis. So the differential diagnosis is basically vestibular neuritis versus posterior circulation stroke in the acute vestibular syndrome. And Hodson and Balow defined acute vestibular syndrome when the patient presents with severe vertigo, nausea and vomiting, spontaneous nystagmus, and postural instability. Now, spontaneous nystagmus is defined as nystagmus which you see when the patient is at rest and looking straight ahead, which is called primary gaze, as in this patient here. But in fact, any patient who has dizziness, nausea, vomiting, and unsteadiness and has any nystagmus at rest has the acute vestibular syndrome. By nystagmus at rest, I'm not referring to nystagmus seen during a positional test such as the Dix-Hallpike test. Nystagmus at rest is when the patient is just sitting or lying there for a while, and you see nystagmus when they're looking straight ahead or if they look 30 degrees off to one side or the other. This woman came to the emergency department a few days after her onset of vestibular neuritis, and she had no spontaneous nystagmus. However, when I had her look to the left, I didn't see nystagmus, but when I have her look to the right, initially I wasn't sure if she had any nystagmus, so I put a blank piece of paper beside her head, asked her to look through it, and I clearly saw pathological nystagmus at that point. She screened negative for central features, had no abnormal vertical or diagonal skew, so I did the head impulse test. And you could see a catch-up saccade right there, normal when I test the right side, and then an abnormal catch-up saccade testing the left. So seeing only nystagmus when she looked to the right, but seeing an abnormal head impulse test when it turned left right there is completely consistent with a vestibular neuritis, which is what she was diagnosed with. And the HINTS exam is exactly what you want to use in patients with the acute vestibular syndrome, where they have unsteadiness, nausea, vomiting, persistent vertigo, and nystagmus at rest. So the acute vestibular syndrome and the HINTS exam, both very useful terms to be aware of and to use in clinical practice. So where did the TEVS and SEVS come from? And do they have value to ED docs when they're trying to figure out dizzy patients? Well, in 2015, Neurologic Clinics published an entire edition devoted to emergency neurootology with many of the world's vertigo experts as authors, including 3 emergency physicians, one of whom was Jonathan Edlow. And 3 neurootologists, true experts in dizziness vertigo, authored this one section on the classification of vestibular disorders. David Newman-Toker, one of the primary authors of the HINTS exam papers, was one of them. You can tell they're on a completely different level of understanding and knowledge when they come up with something as complex as this. their four-layer framework of the classification of vestibular disorders, and I'm sure many neurotologists love reading about this kind of stuff. But I can assure you that non-vertigo dedicated clinicians, such as primary care physicians and ED docs who try and sort out the undifferentiated dizzy patient, find this is about as inviting as trying to figure out what the Rosetta Stone is trying to tell us. And things were still pretty complex in what was the original titrate article, written by David Newman-Toker and Jonathan Edlow. And titrate stands for triage, timing, triggers, target examination, and test. I'm not a big fan of acronyms to remember things, and this one now often gets shortened down to the timing and triggers approach. And within the pages of the titrate paper, it introduces the concept of 6 different vestibular syndromes. The spontaneous episodic vestibular syndrome, triggered episodic vestibular syndrome, traumatic toxic acute vestibular syndrome, spontaneous acute vestibular syndrome, and spontaneous chronic vestibular syndrome, and context-specific chronic vestibular syndrome. And in this algorithm, also in the titrate paper, it lists a total of 22 different causes of dizziness. I remember in early 2016 showing this to a friend and seasoned academic emergency doc with an interest in stroke research. He just shook his head and said, "We aren't going to use that." And sure enough, you don't see David Newman-Toker or Jonathan Edlow promoting this version of the timings and triggers approach anymore. Or at least not for emergency physicians. And to add to those 6 vestibular syndromes, others have defined the ATSV, acute transient vestibular syndrome, as isolated vertigo lasting less than 1 day. So that's 7 vestibular syndromes now. But things did settle down a bit 8 years later. This is in 2023 when the Grace 3 paper came out, in which Edlow and David Newman-Toker were 2 of the 19 authors. They did drop a few syndromes but kept TEVS and SEVS, and also further subdivided AVS, which was originally only patients with nystagmus seen at rest, to AVS with nystagmus and AVS without nystagmus. More on the implications of that later on. As well, they mentioned isolated audiovestibular syndrome, so that would make 5 vestibular syndromes that were in the Grace 3 document. And keep in mind that this is guidelines for reasonable and appropriate care for the acutely dizzy and vertiginous patients in the emergency department. And 5 vestibular syndromes is more than the number of diagnoses an ED doc needs to be able to make in order to be vertigo competent. BPPV, vestibular neuritis, posterior circulation stroke are all you need to know to be competent as an ED doc, in my opinion. If you also learn how to recognize the most common BPP variant and how not to miss those patients with posterior circulation strokes who don't have nystagmus at rest, and you can diagnose vestibular migraine, a very common cause of dizziness, you are now a vertigo expert when it comes to ED docs. And that's still only 4 diagnoses, which is 1 less than the number of syndromes Grace 3 brought up. But nowadays, most people only use 3 vestibular syndromes, and as I have already said, the OG of vestibular syndromes, original gangster, is the AVS, acute vestibular syndrome. And it's hugely useful because that's where you can use the HINTS exam to rule in vestibular neuritis and thus rule out a stroke. But what about SEVS and TEVS? If you do manage to remember what these vestibular syndromes are and correctly identify which syndrome your dizzy patient fits into, spontaneous episodic vestibular syndrome or triggered episodic vestibular syndrome, how many dangerous diagnoses does it eliminate from the differential for TEVS or SEVS? 0. Do the various vestibular syndromes guide you to what diagnostic imaging your patient may need? No. Do they tell you what treatment would benefit your patient? They do not. Are the 7 vestibular syndromes valuable for vertigo experts and researchers that need a deep understanding of all vestibular disorders? Yes, they likely are. So sure, teach them all the vestibular syndromes. But true vertigo experts, of which I am not one, are quite rare, and most clinicians that are called upon to assess the undifferentiated dizzy patient will get no benefit from knowing SEVS and TEVS. They'll only get more confused. Am I the only one who thinks it's okay to focus on key diagnoses for frontline clinicians? In fact, there's recently been an update on the previous classification of vestibular disorders, which includes the original 3 vertigo experts, but now has 19 authors who are the who's who of vestibular research. And they've cleaned up the 4-layer concept a bit, and importantly, also stated that it's okay for some clinicians to focus on specific diagnoses. And that's exactly what I suggest we do. Of their list of 7 cardinal vertigo diagnoses, there's only 3 that are on the must-know list for ED docs. And they are BPPV, because it's so common and so curable, stroke, the disease that makes us fearful and creates much of the dislike of dizziness that many of us have, and vestibular neuritis, which is often the diagnosis made when dizzy strokes are missed. And what will diagnosing these 3 causes of vertigo get us? If you can definitively diagnose BPPV or vestibular neuritis, you've ruled out a dangerous cause like a stroke. It also decreases unwarranted diagnostic imaging, which is a huge problem right now in dizziness, and it guides the clinician to the proper treatment. Add the common BPV variant of horizontal canal BPPV, and also know how to rule out a stroke in dizzy patients without nystagmus, and know how to diagnose vestibular migraine, and you are now a vertigo expert, at least when it comes to primary care doctors and ED docs. And the current state of vertigo education and practice in the real world is that there's no evidence to support that the average frontline provider can reliably diagnose even the typical presentations of BPPV, vestibular neuritis, and posterior circulation stroke. Can you imagine if most brand new medical school graduates couldn't diagnose the classic presentation of pneumonia, pulmonary embolus, and asthma? That's kind of the equivalent of what is going on right now with vertigo education and practice. Why do we think it's okay to let them graduate unable to diagnose the classic presentation of BPPV, vestibular neuritis, and dizzy strokes? Here's an example of how 4 pieces of information about BPPV and vestibular migraine could lead even a vertigo novice to the right diagnosis. Patients with BPPV generally complain of less than 2-minute episodes of dizziness brought on by position change. They have no nystagmus or dizziness when they are at rest. The Dix-Hallpike test shows vertical and torsional nystagmus towards the downward ear. Vestibular migraine patients have had more than a handful of dizzy spells over a long period of time, which usually lasts from minutes to days. They have a history of migraine headaches, and most dizzy spells have a migrainous feature associated with them. The Dix-Hallpike test will either show no nystagmus or nystagmus not typical for BPPV. Now, if we label both these diagnoses with their episodic vestibular syndromes, does this make it any clearer? Whoops, I'm sorry, I put the wrong ones on. You probably didn't even notice. Now remember the "what do you mean by dizzy" approach? One of the criticisms of this approach is that patients' description of the sensation of dizziness sometimes involve 2 different answers, or they change their answer. So this could not lead you to a reliable differential diagnosis. Well, guess what? Same problem with the syndromic approach. Take vestibular migraine. It's placed in the spontaneous episodic vestibular syndrome bucket. But in fact, patients with vestibular migraine often describe a very positional component to their dizziness, fooling some to think that it's a TEVS like BPPV. And some dizzy episodes last for several days, which might make you think it's an acute vestibular syndrome. And with BPPV, the classic triggered episodic vestibular syndrome, 10% of patients will endorse persistent dizziness, again making you think it could be an AVS. Or they could be nauseated for 15 minutes after the paroxysm episode of vertigo, and so you might think they are having a spontaneous episodic vestibular syndrome. And then there's the fact that some dizzy strokes can present without nystagmus, which would mean that they wouldn't fit the classic definition of an acute vestibular syndrome. Unfortunately, in my opinion, the vertigo experts decided to alter the definition of AVS so that AVS would capture more strokes. So that meant instead of nystagmus at rest being a defining characteristic of AVS, it's only something that may or may not be present. In fact, at this point, all you have to do to fit in the new definition of acute vestibular syndrome is say you've been dizzy for a day. And this has real-world consequences. When you look at the recommended diagnostic algorithm in the GRACE 3 paper, after checking for obvious neurologic findings, which doesn't include all the central features that I suggest you look for, you then look to make sure the patient isn't suffering from some kind of general medical cause like sepsis or carbon monoxide poisoning. And if not, then if the patient has continuous dizziness at the time you see them, they have the acute vestibular syndrome. And that leads you to doing the HINTS exam on all BPPV and vestibular migraine patients who have persistent dizziness. And when their head and pulse test is normal, that will create unwarranted concern for a stroke in these patients. Again, my Big 3 diagnostic approach starts with screening for central features, then looking to see if they have one of the 2 non-dangerous diagnoses, and perform the right bedside test on the right patient, the Dix-Hallpike test on suspected BPPV, and the HINTS exam on those with the acute vestibular syndrome. Because by ruling in BPPV or vestibular neuritis, you rule out a dizzy stroke. Those who screen positive for central features, or are HINTS exam central, should be worked up for stroke. And this allows you to appropriately treat the patient and provide information and prognosis on their specific condition. But what about that patient who is having a stroke but has no nystagmus at rest? First of all, many will be picked up by screening for central features. Secondly, if they are persistently dizzy and have no nystagmus at rest but have a new objective difficulty with walking, these are very concerning patients. Mochner showed that they have a 33 to 50% chance of finding the cause on a delayed MRI, mostly strokes. So if they are constantly dizzy, have no nystagmus at rest, first look very carefully for nystagmus on lateral gaze, use a blank piece of paper to remove fixation, and if they have nystagmus, then the HINTS exam is the thing to do. If they don't, watch them walk. If they have a new objective difficulty walking, this isn't vestibular neuritis, and they have a high risk of stroke. And the last piece of the puzzle, what if they complain of constant dizziness, screen negative for central features, have no nystagmus at rest, and have no objective difficulty walking? I've said before that these people are likely very low risk of stroke, but I didn't have any evidence to support that statement. But just a few months ago, Smith published a paper of 311 dizzy patients who were referred to neurology as a stroke code. And in this study, if the patient did not have an objective gait abnormality, this had a 99% negative predictive value for a posterior circulation stroke diagnosis. So there is evidence to support the idea that patients with constant dizziness who screen negative for central features, have no nystagmus at rest, and no objective difficulty walking are at a very low risk of having a posterior circulation stroke. You should consider BPPV or vestibular migraine in these patients, or some general medical cause like UTI or hyponatremia. And here's a last thought. If you're trying to teach me what kind of birds these are, don't start by telling me that the one on the left is in the Corvidae family and the one on the right is in the Turdidae family. Tell me that the left large bird that says caw is a crow and the right one that's smaller and has a red breast is a robin.
If you've managed to watch this whole video to the end, well, congratulations. I hope it'll make you consider how you should be teaching vertigo to others. And maybe you'll come to the same conclusion that I always have, which is the simpler way is usually the best way. And as usual, thanks for watching.